Scott. I am the account management lead, so I oversee all of our ICB support for the Type 2 Diabetes Path to Remission programme. There's some really fantastic sections in this webinar today that you'll be hearing from. So we're joined by Harry Macmillan, our Chief Partnership Officer, who will set the scene of the current landscape and what is happening in the future with this service. Dr. Ellen Fallows, our Medical Director, and Catherine Gill, one of our engagement leads, who will talk you through a really new, exciting approach to identifying and engaging with eligible patients. So as a reminder, again, if you wouldn't mind just keeping your microphones muted throughout, there will be an optional 15-minute Q&A at the end, should you wish to have any specific questions. Any questions you do have, please do pop them in the chat as well. And as a reminder, we will be circulating these slides and the recording of this webinar after the webinar has concluded, either later today or first thing tomorrow morning. So within this webinar, we'll be covering quite a lot in the next 45 minutes, so we will move through at some pace. We'll be giving you an update on programme outcomes. Harry will be talking us through what T2DR looks like in 2026 and what the future looks like. Ellen will be taking us through medication considerations and identifying suitable patients, identifying patients, eligible patients, and how we talk to those patients about the programme, and then next steps. So I guess the majority of you on this call, if you have never referred into the service, welcome, and thank you so much for your interest in learning more about referring into the service. For those of you who do actively refer into the Type 2 Diabetes Path to Remission programme, thank you very much. We do deliver the programme across 13 different ICBs right across England. To date, we've had over 1,700 practices across those 13 ICBs refer into our programme. And looking at the data from last year, we had over 4,000 people actually start this 12-month programme to support patients to possibly achieve remission. To date, we've had over 10,000 people that have started the programme. So we've got lots of evidence and experience of supporting people in the best possible way to give them the best opportunity to achieve remission. So just to share some up-to-date outcomes with you all, so this is taken from our full data set, that the average weight loss at the end of the total diet replacement phase, which is that initial 12-week period of meal replacement products, is 12.5%, with weight loss maintained at 12 months at 10.7%. So quite clinically significant weight loss achieved at both 3 months and 12 months, with really encouraging retention, 78% at the end of that total diet replacement phase at 12 weeks and 62% at 12 months. We are seeing retention increase, and last quarter, we actually achieved 67% of starters actually completed the programme over the 12-month period. Now, there's a correlation with sort of how quickly people access the service. We have fantastic response times, and patients are contacted within the 2 working days of the referral being received, and people do not have to wait too long before they're able to start their chosen delivery format. So once patients do access our service, just in terms of their expectations of the service that they will receive, we always endeavour to try and ensure that patients do not wait a long time for this service. So there is very reduced waiting times at this present moment in time. There's, if they do opt for the digital programme, there's a fantastic digital app that's very interactive with the ability to chat to their coach. If they do opt for our in-person programme, we do endeavour to put on lots of local venues that are accessible, that's in the heart of their community, so they're not travelling long distances to be able to access this service. We've got 20 TDR products to choose from for that total diet replacement phase that are all completely nutritionally balanced. There are all gluten-free with plenty of vegan options as well. And we do have what we call premium fibre, highly soluble and IBS friendly, which does help improve digestion. So patients can expect a really good quality service they're able to access quickly, and a fantastic range of meal replacement products. So I'm going to hand over to Harry McMillan, our Chief Partnership Officer, who will now take you through the current and future landscape. Thanks, Harry.
Thanks, John. Nice to see you all. If you go to the next slide, please, John. So this is just going to give you a very quick overview, because it's obviously a time of acute change across the system of primary care and ICBs, and we're very, very aware of that, particularly the changes that are personally impacting many ICB and cluster colleagues, some of whom we've been working with for a long time. So we're, I guess the first thing to say is that we are acutely aware of the impact, both personally and on a system basis, of some of the changes that are happening and the associated kind of disruption that there might be in certain services, be that support for this program, be it communication, etc. We're doing our best, as you'll see, to support with those things. I guess the good news is that in that landscape of change, this program has now got some good visibility. So the Type 2 Diabetes Path to Remission program will be added into the next Healthier You framework, and more of that in a minute. What that means is that it will be commissioned alongside other services, and that reprocurement is actually starting, in theory, this week. So it's very imminent. However, despite starting in March, at least theoretically in March, new contracts will only go live from the 1st of January. So that means that for the rest of this calendar year, the existing contracts will continue. So we'll continue to be the provider of the service for certain over the next 9 to 10 months, at the very least. We'd obviously like to continue doing it beyond that, but that's a separate issue. But for now, there's continuity of the program over up until at the very least the end of December, and that's for referrals. So anyone you refer by the end of December will still have another couple of months to actually start the program, and then the program itself, as you know, is a 12-month program. So that means that this program, for anyone you refer to it, will continue to be available to them for as long as they need to actually get through the 12-month program. The other good news is that, as many of you know, Momenta is now a Lever Healthcare company. It's part of Lever Healthcare Group. But our bigger parent means that we have more capacity to support any of your patients. In conjunction with that, the NHS milestone caps, which were reinforced partway through last year, which was a bit disruptive, have been relaxed and are continuing to be relaxed. So that means combination of continuity, plenty of capacity from both ourselves and from NHS England. So please keep referring. And we will work with as many of your patients as you can send us. And in the shifting environment, we're working quite hard to support the service as well as we can, particularly with yourselves in primary care. So we've invested in some additional engagement lead support, and John and others will talk more about that in the latter half of the presentation. And we also have some interesting new ways to support reducing the workload from a primary care perspective, which again, John and Catherine will come on to later. And if there are ICB teams that are available and other more local, either locality or PCN level primary care teams, we will, and even at practice level, we will continue to support you as best we can and work proactively to make sure that you've got the right tools and resources in place to make referrals as straightforwardly and with as much support as you need and we contact them as quickly as possible. Next slide, please. So in terms of what the next Healthier You framework will look like, this is just background for you, but hopefully will fit into the bucket of making life a little bit easier going forwards. The Healthier You framework, which is currently the framework under which the Diabetes Prevention Programme is commissioned, as well as the emerging snappily titled BSOP, Behavioural Support for Obesity Prescribing, and also a long-term condition prevention programme pilot is currently commissioned under. That will be extended, as I say, starting to accept referrals from January next year, and it will include the type 2 diabetes path to remission. So that means that as a practice, as a PCN, as a ICB cluster, there'll be a single provider who will be doing all of those services, which will simplify pathways or simplify reporting and delivery and comms for your point of view. So there'll be fewer people to go to for a larger number of services. In terms of timing, those new providers will be announced in September, October as a theory, with a mobilization over the last calendar quarter and a go live in January in theory. And again, that will give us, when the T2DR program is incorporated into Healthy You, it will give us an opportunity to actually really embed it more than it is at the moment, and to further improve the integration with other local services, which we've been working on, as you know, but will enable us to keep going on that. And then the final thing, which is important both now and in the future, now it's important because the weight management enhanced service that provides £11.50 incentive for referrals to this and other programs will be stopping at the end of March. So that means that any of your referrals that you send to us over the course of the next 3 or 4 weeks or 3 weeks will still potentially qualify for that, whereas in April they won't. However, you will be eligible to draw down some funding under 2 new cough indicators for this and related services. How that detail how it's going to work in detail is still not yet completely transparent. But the bottom line is there will still continue to be incentives for referral into this kind of structured weight management program. However, the form will change from April. So that's just a bit of background again. And then I'm going to switch tack briefly. So that's the current landscape and the future direction of the service. And just to save you bouncing back and forth with me again later, the next slide is a completely different topic. And might appeal to a few of you individually. So the Lever Medical Director, Dr. Ellie Heath, is interested in doing some collaborations around service evaluation. So be very interested in learning more about any of the clinical outcomes from your patients that we don't have access to. So we collect lots of data around engagement, weight loss, etc. But we don't have access to information around 12-month HbA1cs unless patients tell us, or medication deprescribing, represcribing rates, etc. So if you're a GP, a nurse, a pharmacist, we'd be very interested in talking to you about potentially exploring some of that in more detail. So these slides will be circulated. You'll have Eddie's email there at the bottom. Please feel free to get in touch with that if you are interested in discussing any of these potential projects that you might be able to work with us on, and we'd be very happy to support with. And I've just seen a note in the comments from Amin about never having received payments for T2DR referrals. We'll get back to you on that. But you'll be delighted to know that's all I've got. It's all you've got from me. And now I'll hand over to Dr. Alan Fallows, our medical director. Much more interesting session.
Thanks, Harry. Hello, everyone. And I'm so delighted to see so many of you on such a sunny day. Thank you for giving up your lunch break. So Harry's kindly looked at the sort of logistics and the shifting sort of political landscape of services that's going on at the moment. as ever in primary care, I'm going to be briefly talking about the changes in the clinical landscape of the treatment options that we have for obesity and type 2 diabetes in respect to remission. Next slide, thank you. So we all know the range here. We've got lifestyle support going all the way to bariatric surgery, and this is where the Path to Remission program fits. This is a low-calorie total diet replacement and a year-long program, as Harry's mentioned, that sits nicely between the lifestyle behaviour and the medication interventions. Next slide, thank you. And some of these interventions we have vary depending on eligibility on BMI, but that's changing more and more as we're seeing, for example, new NICE guidance focusing more on the comorbidities. Next slide, please. So I think it's really important to support patient choice at the moment, because we do seem to have more options for weight loss that leads to remission, and we always need to take this shared decision-making approach. And I find this really useful clinically. What matters most to you right now about your health, and understanding a bit more about their background and what's going on in their life, which will help you understand whether this is the right sort of intervention for them. Next slide, please. I think it's worth drilling down into thinking about what are the issues with these different options. So in terms of lifestyle and behaviour programs, they tend to give less significant weight loss, and they tend to involve a lot more effort, but they are low risk and may have fewer side effects. And the latest data comparing them to GLP-1 use in weight loss suggests that they may be more sustainable, in fact. But there's no way people can engage in this stuff, and there are a lot more services coming through and good websites now on the NHS and the new NHS app, which you can use essentially as a lifestyle medicine survey. So the lifestyle quiz, very useful at directing patients to the services available. Path to Remission is actually relatively quick in terms of the results people see. They can improve blood sugar levels within days, blood pressure within weeks, and weight following that. And we have really good quality data for this, which I'll briefly cover. It's very well supported, it's very safe, there are minimal side effects, and it addresses the whole person, and it seems to be more sustainable. And as Harry said, very little weight compared to the other services, which can be patchy. And comparing this to the use of GLP-1s for weight loss or diabetes, although the results can be rapid, we actually lack real world data that can be higher risk. And I'm seeing very little support for nutrition and lifestyle, and I'll touch on why I'm worried about that. And as you all know, that there are long waits and shortages in supply and so on. Next slide, please. I think it's worth touching briefly on thinking about gradual versus rapid weight loss. It does help us think about who might be most suitable for programs like Path to Remission or GLP-1 and so on. There's no evidence that the rate of the weight loss matters necessarily for sustainability. That tends to be the intervention. So obviously bariatric surgery is the most sustainable, and then probably, if successful, the lifestyle and behaviour programs. But actually that Path to Remission, whilst it's a food on prescription and a lifestyle behaviour program, is probably very sustainable as well. And it's not unsafe to lose weight rapidly, but it can carry risks. We don't recommend rapid weight loss for people with biliary disease, and that's why it should be a relative contraindication to the programme. Untreated retinopathy, active or significant cancers, and obviously pregnancy and breastfeeding. There are some worries with people with recurrent gout, but we have supported people on the programme with that, and it's not a contraindication. I think there are also risks around sarcopenia, malnutrition and frailty, and those with complex polypharmacy or past eating disorders and personality disorders and things like that. But rapid weight loss can be very appropriate for people who have a time-sensitive need to lose weight. So people waiting for hip and knee replacement, other elective surgeries, people wanting to conceive, becoming eligible for IVF, and certainly if they have diabetes and obesity, the Path to Remission program can really help them rapidly lose weight. And rapid weight loss can be suitable for those where there is support available, and it is on this program because there's very intensive support, particularly during the first couple of weeks. Next slide, please. Next slide, we'll skip this one. So just touching on the evidence base for this programme, it's based on the randomised controlled trial, the direct study up in Newcastle. So and now we also have real world data, which is the really important thing for you and I as clinicians. And that safety data is very reassuring. We have evidence of a couple of years of sustainability now, and it's tested in a UK population, unlike the new weight loss drugs. and in areas of deprivation. So 25% of the participants of the direct study were in the most deprived quartile. And as I said, this is a food intervention. So if people are struggling to afford food, it is free essentially in this programme for the first couple of months, along with this year programme. Next slide, please. So the priority groups from our clinical experience in terms of who does best, it seems to be those who are on fewer than 3 diabetes medicines, who are recently diagnosed, and it tends to help if you've got nutritional concerns, including those on the GLP-1s, so people following restricted diets are not able to access, or where you think food is a big issue or maybe contributing to their type 2 diabetes. But obviously you can focus on any particular priority groups. We also seem to see that people who are newly diagnosed tend to be more motivated and may achieve remission more easily. Next slide, please. And let's think about the programme in terms of the new landscape, where we have these new weight loss medicines that work through, mainly, I believe, through appetite suppression. And many of our patients are buying them privately, or we're using them under the diabetes licence at lower doses for type 2 diabetes, but also in some areas for obesity anyway on the NHS. And whilst we are seeing significant rapid weight loss and other benefits for comorbidities from randomized controlled trials, these are mainly done in America. And so they remain relatively high risk new drugs. Certainly Mounjaro is a black triangle drug. That means that we're still waiting for MHRA data from real world use. And I worry about the lack of research into people's nutritional status before, during and after using these medicines, and actually what they're eating. And the great thing about the Path to Remission programme is we've got their nutritional needs covered. That we are seeing side effects and high discontinuation rates. Don't really know how sustainable use of GLP-1 is in the real world. And obviously you and I know about the slow rollout and the logistic issues we have. Next slide, please. And just to emphasize this issue, that many people with obesity and type 2 diabetes, we know have a degree of malnutrition despite their obesity. And what we mean by this is that muscle wasting, sarcopenia, vitamin and mineral deficiencies, and microbiome disturbances. And next slide, please. Where this program helps is that the replacement products cover their total dietary needs. I have had colleagues who are worried that people are somehow starving or going to risk mineral deficiencies, vitamin deficiencies. That's not the case, and their protein needs, particularly with these NUPO products, may be better met. So it is just a low calorie intervention. All the other nutritional needs are there, and very intensive compared to many of the programs I'm seeing. Health coach support in those early few weeks, weekly support and supervision by myself. So I deal with the queries we see week to week, and we're monitoring weight, blood pressure and blood sugar levels, which is a huge amount more than we're seeing in terms of the support being offered around GLP-1s, which particularly for people with diabetes, used under the diabetes licence dose, they're almost getting no support out in primary care for nutrition. And in my clinical practice, what I'm seeing is that people's appetites are so significantly suppressed that they're eating very low calorie, not meeting their nutritional needs. A real life example is a patient of mine just eating a couple of slices of pizza every day. Clearly not going to lead to the health outcomes that we're wanting, not enough monitoring. So this programme can work very well. Next slide, please. So I want to make sure that we all know that there's no need to stop the GLP-1 medicines prior to referral. I feel it's quite cruel actually to take off that appetite suppressant just as we're asking people to restrict their diet. There's no contraindication to using these medicines during the total diet replacement phase. In fact, I believe that it is safer to use these medicines with total diet replacement because we know people are getting their nutritional needs rather than having a poor quality restricted diet if they were to eat freely and obviously the previous diet they were probably having. Next slide, please. Just want to touch on the new nice type 2 diabetes guidelines, which are shifting us to use more metformin modified release, which I hope most of us were doing anyway. It's just nicer, isn't it? But we're being encouraged to have earlier starting of the SGLT2s and the GLP-1s, and there are clearer guidelines as to who might do better. For example, the early onset people with early onset diabetes we need to start them earlier on these medicines. But it's worth pointing out that there is a theoretical, I've never seen it or really seen much work on it, but of diabetic ketoacidosis with these SGLT2s and a lower carbohydrate diets, which the meal replacements actually are, whilst being low calorie. So you can delay the SGLT2 start or pause whilst they're on the total diet replacement phase. So it is a contraindication to be on those medicines before the program. But once they're on the healthy eating phase after the first 12 weeks, it would be safe to start them if they needed it. But we need to know that. So make sure their health coach or the patient knows that if they had a reset during that year-long phase, if they regained weight, then they shouldn't be on these medicines and we may need to pause them again. So that's just to be mindful of this issue with these new guidelines. Next slide, please. So in summary, I think we need to consider the risks, benefits and side effects and various unknowns of the different approaches we now have for our patients, and think about the issues of rapid weight loss, particularly around biliary disease. And if you're worried about nutritional status, then this programme is really good for that, because they get free food on the NHS for those 12 weeks. And then thinking about patient preferences and what's going on in your area, waiting lists and availability and so on. Next slide, please. I just thought it'd be useful to share who we found do best on this programme, and certainly people who are really motivated, and that tends to be at diagnosis, or people who may be thinking about insulin or running out of options. But also it depends on what's going on in people's lives. If people are preparing for surgery, as I've mentioned, or major life events like thinking about starting a family or upon retirement where they have more time and motivation. I always worry about missing a late diagnosis of type 1 diabetes or somebody with pancreatic insufficiency. So if we're really sure it's type 2 diabetes, that really helps. Again, people who are in a good place in their life and they're able to make changes, that can help. So people, you know, moving home or recently bereaved, things like that can make it more challenging. But that said, we know that nutritional interventions improve mood, and we do see that, and our health coaches are amazing and seem to be dealing with a lot of complex issues, because people with type 2 diabetes and obesity tend to have very complex lives and face significant difficulty. So it can be quite helpful to be improving nutrition. But at the same time, if there are big life events going on that are challenging, it can be more difficult. People on fewer medicines seem to do better, and I do worry about people on things like lithium and digoxin with rapid weight. It can be a bit more complicated, and same with those with digestive health issues. So people with very active colitis, major food intolerances, history of gallstones, as we've mentioned. But most importantly, we're very grateful for your support, and particularly the nurse practitioners, the nurse prescribers in diabetes. You guys are amazing. You're offering a lot of support for people. So thank you for supporting our patients. Next slide. Oh, that's it. Thank you very much. Hope that was useful.
Brilliant, thank you. So I'm one of the engagement leads who works across the Type 2 Diabetes Path to Remission programme. So I'm just going to talk to you a little bit about eligibility and referrals and searches, and also some ways that you can work to engage with your patients. So just to give a very quick recap on eligibility, all of these slides will be shared afterwards, and all of this, or most of this information, is included on our referrer websites, which we will include links for as well. But just as a bit of a reminder, so many of you are probably aware that the age range has been relaxed a bit more recently. So used to be aged 18 to 65. However, we can now accept participants over the age of 65, providing it's deemed that they are clinically appropriate for the programme and that any benefits would outweigh risks. There's ranges for BMI and HbA1c. So HbA1c just differs slightly depending on medications that the patient's on, but in all cases under 87. Must have been diagnosed with type 2 diabetes within the last 6 years. And then, as you can see on the right hand side, there are some further exclusions. So being on insulin, being pregnant or breastfeeding, and various medical conditions as well. What I would say is, if you are a bit uncertain about a patient, then do reach out to your engagement lead, because we can always have a look at things on a case-by-case basis, refer them internally, and just have a look to see if they would be suitable for the programme. Thank you, John. So in terms of searches and referral forms, so again, I appreciate some of you on this call will be very familiar with this process. This might be very new to some of you, so do reach out for support. As I said before, we do have referrer websites for each individual contract. So on there you can find lots of resources, search tools, guides on how to run searches, how to fill out referral forms and everything. So do reach out if you do need that support. Searches should already be built into your clinical system. So I'm going to give some examples over the next few slides on how these can be used. But they mean that you can search your patient database and identify people who should be eligible for this programme, which is really, really helpful for doing that kind of targeted approach. We can also send out guides and information and offer training on how to complete those referral forms. So again, you will be able to find those in your clinical systems already. The majority of information on those referral forms will auto-populate for you. So this includes the patient's information, contact information, and also the majority of the medical information that we need. So that would include their date of diagnosis, their HbA1c, weight and blood pressure, but it's always worth just having a skim through to check that nothing's missing and also to make sure that they are within the right ranges. So date of diagnosis within 6 years, HbA1c, weight and blood pressure all within the last 12 months. Thanks, John. The second part of the referral that we need completing is the medication adjustment form. So this is all within the same document. So this does need to be signed off by someone who can prescribe or de-prescribe. So this varies, to be honest, across different practices and PCNs. So if I just have a think about some of the people I work with, it's sometimes a GP, it could be a nurse who can prescribe and de-prescribe, and actually often pharmacists as well. So it just depends who this kind of sits with within your practice. Quite simple to work through. So you just need to go through, complete all sections. So depending on the contract area, you will have either 2 or 4 tick box questions. So just yes, no questions to begin with. And that's just around different types of medication that the patient is on. And then as you can see from the example on screen now, you would just need to complete the table with any relevant medications. So that is primarily blood glucose and blood pressure lowering medications, and any others that can be affected by weight. So just as an example, if you had a patient on metformin, you would pop that into the table. You would input the action, so whether they are to continue, stop or reduce the medication, and then just state that that will be from day 1 of the programme starting. You then just need to make sure the patient understands that fully, and they will take a copy of this away, or you can send a copy over to them. And just make it really, really clear that the patient is to make these changes from day 1 of the programme. Because we will have a copy of the full referral form, our onboarding team and the coaches can just make sure that patients are completely aware of what they need to be doing before they start the programme as well. Just one final thing on this. So within the referral form, there is a really simple and easy to understand flow chart, which explains what you need to do with medications, depending on how many medications people are on. But again, if you do need any support on this, please do reach out. Okay, so what I'm going to talk to you about over the next few slides is identifying interested patients, and some of the really good things we have going on within the engagement team and some of the ways that you can approach and engage your patients. So I've just mentioned the searches that are available for you. So these allow you to search your patient database, screen patients who are eligible or potentially eligible for the programme, and then this can be used in a number of ways. So you could invite or send a text message to these patients, explain that they may be eligible and invite them in for a appointment. But also these can be used really well with patient events and our new landing page, which I'm going to come on to very shortly. Then, oh, sorry, just go back, John. And then a couple more things on here. So then there is the usual point of care as well. So just taking that opportunity to speak about the programme at the point of diagnosis or during annual reviews, or if you get approached by a patient. So sometimes they will see this information or hear about it from somebody else. And then patient information sessions and resources, which is where us engagement leads can really support with. These are becoming increasingly popular and a really effective and efficient way to target larger cohorts of patients and ultimately to take some of the work away from you as well. So we can deliver these at practice level, PCN level, but also at a more community level. So if you do have any events coming up, so health and wellbeing days, diabetes days or events, we are happy to come along to promote the service, to speak to patients, so that you are able to support multiple services and kind of community things within that same setting. Thanks, John. Okay. So firstly, having a look at patient events. So as I mentioned before, these are really great ways to speak to and refer multiple people at scale. We're really flexible in terms of formats. So we do run these in person and also virtually. So in person, if you've got space, this could be at your practice or a local venue or community centre. And virtually, we can run these through Teams as well. So it really just depends on your local need, your demographic, what you think will suit your patients, how many people you could expect. And as you'll see from a case study soon, we can do a bit of a combination of the two as well. So the way these work, just briefly, is once a date and time was decided, we would set up a link which can be sent to patients. So from that search, you can send an SMS to patients with a link to sign up. We would run a simple, really informal session explaining the programme, plenty of opportunity for questions. If we are there in person, we can do some product sampling, so give some samples of the shakes, bring along workbooks and other resources. And it's just a nice opportunity to kind of get more patients together. Just to give a bit of an example on this one of a recent one from one of my areas. So we had a PCN in Dorset who back in November ran 4 back-to-back in-person sessions. Because they used one of their treatment rooms, which was quite small, they had 4 sessions, which allowed 10 people in each. And then they followed up with a virtual event at the end of January. So really kind of accessible. So targeting people who wanted to come in person, people who wanted to attend online. And across the 2 sessions, we got about 40 eligible referrals, which is a really, really fantastic result. So really engaging for the patient, and also helps you because ultimately you're not having to spend 5 to 10 minutes with each individual person explaining the programme, helping them to understand it and answering questions. Thanks, John. Next slide. The next thing we have, which is very new and exciting, is our practice-specific landing page. So this has only launched in the last couple of months or few weeks. So on request, we can create a landing page which is bespoke to your practice or PCN. So you can see a couple of examples of this on the slide. So the first one showing just for one practice, and the second one showing a PCN landing page which lists out all of the practices under there. So if you are interested, again, reach out to your engagement lead, and we generally can get these turned around very quickly. So we can often get these out to you the same day. So similar approach to before, you can run your search to identify potentially eligible patients, send them a text message with a link to this page, and they can access the landing page, learn all about the programme. And one of the reasons this was put together was, again, to take a lot of the burden off you, so having to explain the programme to lots of people. But we've really tried to make it simple, informative, it's very visual, there's a nice 1-minute video on there, We've used kind of thumbnail visuals rather than big chunks of text. So really easy to understand and work through. And then at the end of the landing page, patients can fill out a form to let us know if they would like a referral, if they would like more information, in which case they receive a slightly longer video from one of our other engagement leads, or they can let us know that they're not interested at this time. We would then send you a weekly summary, so that can go back to whoever you want at the practice or PCN, so whoever is coordinating this. And that just means that you receive a list of really motivated, knowledgeable patients. You know they've attended, because we can do this for patient events, so you know they've attended an event or seen the landing page, and they would like that referral. So again, if you do want any more information, do reach out. But if we flick to the next slide, thank you, we've just got a few more benefits. So again, a bit more personalised. So we appreciate patients probably get a lot of information. So being able to open up this page, having it directed towards them through their practice name is really nice. Really clear information. And for yourselves, it does reduce potentially necessary appointments and admin. So again, you're not having to explain the programme to lots of people. We can send those summaries out. So again, you've got that list of very motivated patients. And your engagement lead will work with you individually to help you get this set up, to help understand how often you want those lists, who you want those to be sent to. And they can work really nicely in collaboration with patient events as well, as a follow-up to people who weren't able to attend. It does help us with planning as well. So we do ask patients if they would prefer digital or in-person delivery. So if, for example, you would send out a landing page and you had lots of people come back who wanted an in-person session, we can start having a look at local venues and lining that clinic up. So initial results have been really strong. We've had over 200 practices request after our soft launch, which is really, really positive. And we're seeing average conversion rates at around 16%. So that's based on how many text messages go out to how many patients come back and request a referral. Next page. Fab. So final couple of slides, I'm just going to run through some case studies on this. So this first one is from one of my contract areas, and this is for Christchurch Medical Group in Dorset. So Christchurch were already referring, so they were already quite a high referring practice, but were really interested in this page. And after they did a search, they identified that outside of the people already referred, there were actually quite a few more potentially eligible patients. In this case, the approach was kind of organised in collaboration, so with the practice manager, diabetic lead nurse, diabetes administrator and IT assistant. So they all work together to identify those patients, send the link out, and then ultimately complete referrals. So the results, off the back of the search they ran, they had 63 patients who were sent a link to the landing page. We had an initial 9 patients request a referral very quickly. They were actually really proactive and sent a text message the following week to non-responders, and we got an additional person request a referral. So 10 requests in total, which was a conversion rate of 16%, so matching the average that we're seeing. This list was then shared back the following week, and it just meant that the practice had 10 knowledgeable, motivated patients. Again, it removed a lot of the admin time of having to have ad hoc and individual conversations with lots of patients. And the way they managed this was to actually set some admin time aside in the following weeks so that they could sit down and just work on a bulk number of referrals rather than, again, doing them kind of as and when, which they found much more effective and time efficient for them. Next page, John. Fab. So final one, and just to mention, you will get this sent out as well, so I won't go through this in too much details, but this is just a really nice case study and example on how the two approaches can be linked together, so a nice blended approach. So Acklam Medical Centre ran an in-person patient event, and then for those who weren't able to attend, followed up with the landing page. So really accessible for people who would prefer in person, or for people who can't attend and would prefer a more digital route. Again, they identified 67 patients, and across the two different approaches had 26 motivated patients wanting a referral. So just final couple of things. Hopefully this shows, if a search identifies, or it doesn't have to identify hundreds and hundreds of patients to be effective, but at the same time, if you are concerned that you are going to have hundreds of patients and you aren't going to be able to manage that, then again, do speak to your engagement lead, because we can support you on breaking that down, identifying smaller cohorts of patients, or sending out text messages to say 100 people at a time over a month or so. So we can work with you to make that workload more manageable. I think next page.
Well, I think
thank you.
I think that's you at the end of that one, Catherine. Thank you very much for your support, and clearly outlining the support that the engagement leads can provide for primary care. Couple of final points is that each of the engagement leads are hosting local ICB webinars where we can really go into a lot more of the detail around what is happening within your ICB, referral pathways, and share examples of best practice across what others are doing to maximise referrals from their practice. I see there's been a few comments around engagement leads and who your engagement lead is. So the slides do get circulated, and your engagement lead is listed here along with their individual booking link. So if you would like a session with them sooner rather than later, I would encourage you to click on their booking link, which will direct you to their calendar, and you can book a slot in from there. And we'll also include our patient and referrer website for each ICB area. Cool. I will stop there and say thank you for everybody's time. It is much appreciated. If you are really keen to get in with your engagement lead sooner rather than later, I would encourage you to review the slides when we send them and book in a session with them. If anybody would like a landing page, as Catherine said, we've got some fantastic examples of how that engages with your eligible patients really well, and we're able to set them up really quickly. Harry, have you got anything to add?
Yeah, just a couple of very quick ones. Outside of any other comments that come in, please keep them coming. If we'll be here for a few minutes if you do. One is I made a horrible typo in my one of my earlier responses that Stacey very kindly picked up, which is our retention rate is over 65%, not over 6%. So thank you, Stacey. That we would be run out of town if our retention rate at 12 months was 6%. And then the only other thing I was going to say is two things. One is someone asked if there's no engagement lead listed for your area. That was Lynn Hargreaves. Please just put a message in the chat with your email, and one of us will get back to you, probably John or Catherine, to help square that circle. And I think that's it from the comments so far.